will be tackling fever of unknown origin and healthcare-associated infections. Okay, so ang konti pa lang nag-join. Please join. Go to joinpd.com and input IUVHVB. pd.com. HVB. Okay. Yeah, so just a reminder for those who only have their backgrounds turned on, but we can't see you, your attendance will not be recorded. Okay? Sige, so let's wait for a few more. Start at 8:22. Ayan, 8:22 na. Okay. All right, so in one phrase or sentence, what did you learn about FUO in children based on the asynchronous or the pre-recorded videos and your readings? What did you learn about FUO? Baka ngayon lang kayo nagbubukas ng ano niyo, notes. To facilitate our discussion as well, please participate, no? Because I only see only 10 out of 48 responders and not even half of you have logged into to Pair Deck. So would you want a synchronous session or not? Yes. Okay, so let's see some of your responses. So there are several etiologies. Yeah, okay. Sino yung majestic? So obviously hindi yan nagbasa or nag-watch man lang ng ano no. Mostly infectious in etiology. Okay, that's actually correct na, especially for children. Should be thoroughly investigated, yes. Rely a lot on history, but most cases are bacterial in origin. Okay, there are difference of FEO and fever without source. Okay, very good. That's actually a very good point. Now, to differentiate between the two because you'll somehow have an idea, di ba, of what are the possible etiologies or how to proceed with their workup for FUO or a fever without source. Okay. Sorry, you rely a lot on the history, but most cases are bacterial in origin. Yeah, that's correct. No, history, the history part is really very, very, very important. No, you don't rely too much on your labs, but of course, you really have to get a good history so that you'll know also what to work up for your patients. Okay. Uh, Unusual presentation, yeah. So it's usually a common source or a common cause, but with an unusual presentation. I think parts of clinical evaluation, better prognosis than adults, yeah, because usually nga, infectious lang siya. As compared to adults, more of hematology or oncology or autoimmune. It's important to categorize them to at least know their etiologies. Yeah, that's correct. So there are different classifications. Diagnostic tests are important to determine the etiology of FUO. Okay, Kawasaki is a differential also. Okay, sige. So let's proceed. Which of the following is incorrect regarding the definition of FUO? So can you please input your answers? Okay, let's see your responses. So actually, ang question there was incorrect, ano? So there should be, of course, a presence of fever, 38 and above, for more than 2 weeks. No identified cause after 3 weeks of evaluation as an outpatient. Okay, so let's see which is the correct definition of of an FEO. So the timeline kasi depends on whether the evaluation is an outpatient, right, or an inpatient. So the classic definition would be the of course the presence of fever. So the fever should be 38 degrees and above. Uh, of more than 3 weeks in the outpatient clinic, no? Or more than 1 week in the hospital. Okay? So the common etiologies of your classic FEO would be infections, inflammatory conditions, and malignancy. Um, for healthcare-associated infections, the fever should have been present for more than a week already and should not have been present or incubating at the time of admission. Because if has been incubating already, so most likely the source or the cause of the fever is what from the community na it's community acquired. Okay, so most common etiologies would be your healthcare associated infections, Clostridium difficile, especially if the patient presents with bloody stools or bloody diarrhea, septic thrombophlebitis. So usually you aside from sepsis as being the source, the IV line, no, it can also cause phlebitis. So that one, you should also be checking for your IV lines if ever the patient develops fever in the healthcare setting or the hospital setting. Okay, post-operative complications if the patient underwent a surgical procedure and drug-induced fever should also be at the back of our minds. Okay, so if for drug-induced fever, if you of course take out the source, if you discontinue the drugs, then the fever expected to resolve as well na in 24 to 48 hours. Okay. So if the patient is immune deficient or has HIV, then there's also the common infections or etiologies that you would be thinking about. No? And these are mainly opportunistic infections. Okay, so FEO in children have a poor prognosis compared to adults. So this was actually raised kanina, no, na learning niya. So is this true or false? I sorry. Okay, so it's actually false now because they have a better prognosis compared to adults. Okay, so most of you got it right. And these are the etiologies most commonly associated with FUO in children. So it's most of the time infectious, but with an unusual or uncommon presentation. And it's bacterial is the most common, no? 59%, followed by parasitic or protozoal, 10%, and then viral, actually 7% lang. So bacterial, TB is very common here in the Philippines. For typhoid as well, no? Salmonella. Parasitic, mga malaria, schistosomiasis, or viral EBV or CMV would be the more common causes of prolonged fever in children. Okay. Fungal, not so much, not so common because they usually occur among immunocompromised patients, no? So so this would be followed by your autoimmune or inflammatory causes or connective tissue diseases, and then malignancy. Okay, now so let's match the characteristic PE finding. So these are the PE findings in the uh, colored oval objects na, and then match them to the most likely cause of FUO. So draw a line on from the cause to the etiology. Sorry, from the PE finding to the etiology. Okay, so let's see your responses. Okay, so rose spots. I showed you yesterday the rose spots. So they should be gotten by everybody so correctly. So yeah, that's typhoid fever, no? So the the physical exam is another very important component of your workup, no, or in your assessment of FEO patients. So aside from the history, of course, a PE finding. So there will be typical PE findings or key PE findings for a specific etiology. But of course, you won't always be able to see them. No? So that's why you also need your laboratory workups. So rose spots, these are again the salmon colored, very discreet macules or papules no, in the trunk. So that's often seen in typhoid fever during the second week. Rot spots are findings in the eyes, so in the retina, no? So for infective endocarditis. So that's why you it's very important to do your fundoscopy uh, for patients with FUO also. No, it's really a complete PE na from head to foot. Okay, so check the eyes, check the ears, check even check the palpate for the sinuses, right? So you can see sinus tenderness giveaway na ito, no? For sinusitis, very important also to palpate for that. Of course, for sinusitis, then there should also be a history of chronic nasal congestion, so around 2 weeks or more. And then, so check the throat, and even do so from the cardiac, lungs, abdominal, extremities. So even check for you should even be doing your rectal exam. No, if you really cannot find the source, so far because there might be tenderness in the area or masses that you might be able to miss, no, in the history. So for pararectal tenderness, you could be thinking of a pelvic abscess. And I um actually I was really I cannot forget the I had but the certain patient that I had, no, I had referral of FUO. And in the history kasi there was really no history of pain on the rectal area or in the anus. So I actually did not do a DRE or direct rectal exam. But so with the further workups, because we really could not find the source, we did a abdominal CT scan. And then the CT scan, true enough, revealed a pararectal abscess actually. So moving forward, no, that's really one of the things that I check for patients with FUO. It's also that could really be one source also. Okay, so conjunctival, ano ba yan? So fusion, okay, so that's for leptospirosis, that's correct. Splinter hemorrhages, saan ba yan? Where do you see splinter hemorrhages? Sa leptospirosis? What body part do you see splinter hemorrhages? May sumagot yan. Okay, so in infective endocarditis po, nails. Okay, very good, Christiel John. Okay. So those are ano kasi, septic emboli, no? That's why they get yung mga rot spots, splinter hemorrhages, those are actually septic emboli from IE. Okay. So this table is from Nelson, so you can take a look at that. Also, so just some examples now of and to further stress, the PE is very important in FUO, no? So there are certain physical findings that may be associated with a certain diagnosis. So you can go through that table. So ito yung mga ano no, rot spots, so hemorrhage in the retina. Of course, if you're not too adept yet at your infundoscopy, you can also refer to an ophthalmologist to really check for yung mga osseolar nodes na very painful na mga nodes in extremities, in the hands, and ito genuine lesion. So I have seen this in an IE patient na mga these are all from septic emboli. So yan, mga splinter hemorrhages. So those are seen in IE. All right. So we have a case here. RJ, a 9-month-old male, was brought to the ER due to a 4-week fever. 4 weeks prior to his consult, the patient had intermittent fever, mostly occurring in the afternoon and night, temporarily relieved by paracetamol. The patient remained active and well, hence no consult was done. So patient was still active. 3 weeks prior, due to persistence of fever, patient was brought to their family physician. So this was about a week already. CBC, urinalysis, stool exam, and chest x-ray were done, which were all normal. The AP opted to give an oral antibiotic for 7 days, which commonly happens, which the patient took with good compliance. However, fever persisted, with the patient becoming more irritable and with markedly less oral intake. Hence, he was brought to the ER for consult. So other pertinent findings were there was positive weight loss, occasional cough, there was no rash, no vomiting, no LBM, no seizures. Okay. Right. So does the patient meet the criteria of FUO? What do you think? Okay, let's see. So he had, yes, yes, okay. So, okay, all right. So actually, yes, no, the patient has been having intermittent fever for 4 weeks already, although the temperature is not really stated, but it was documented fever. And there was already workups, right? So 3 weeks into, or 1 week into the ano, so 3 weeks prior, the patient already had some initial workups done, which revealed um, unremarkable findings. Okay, so the patient meets our criteria for FUO. So let's step up to the diagnosis. Let's say the answer lies at the top of the mountain. So to get to it, there are many steps along the way, right? So what initial steps will you order for a patient presenting with FUO? So please answer. So you're already done now with your well, assuming no, you did a complete history already, a complete physical exam. Okay. So let's see. So the choices there are CBC, electrolytes, blood culture, urine culture, all of the above. So, okay. So these are the initial tests that are recommended. So the recommendation meaning it's really just like a recommendation, huh? But of course you can always tailor fit it to your patient, especially if you are inclined to focus more on a certain organ system, ganon. But if you really cannot find ano, these would be some initial tests that might help you. So CBC, electrolytes, blood culture, urinalysis, urine culture, ESR, CRP, tuberculin skin test or and chest radiograph. So of course, you need to get cultures because, again, di ba, infectious etiology is the most common cause of prolonged fever in children. ESR, CRP would somehow help give you a clue if this is infectious or inflammatory, right? If it's normal, then that would be quite helpful because, oh, this is most likely not a bacterial infection or an autoimmune or inflammatory in nature. Because usually those conditions would give you high inflammatory markers. Now, TST and chest radiograph would be part of your initial TB workup if you're um uh yun, again, if you cannot find a focus for your patient. So the correct answer there would be all of the above, no? So most of you got it right. And now what will be your next step? So for example, you did all of these and then they turned out to be unremarkable, nothing really helped you, no? Or maybe may mga konting ano lang, abnormal, like the ESRCRP. So what will be your next step? So, okay, the choices there are a 2D echo, a transesophageal echocardiogram, bone marrow biopsy, or a whole abdominal CT scan. So let's see. Right. So if the initial test did not reveal anything remarkable, then you can proceed with your abdominal imaging. Okay. So why abdominal first? No, because certain infections like there might be occult abscesses or even malignancy, abdominal tumors, uh, can present with FEO, and they're more common than the other conditions like your cardiac, mga ganon. So you can proceed with an abdominal imaging first. So the algorithm no is there in the lecture notes. So that's from Navarro, the algorithm that I presented there. Okay. So yan, pwede ka mag-imaging ng abdomen or pelvis. And then, so from there, you can somehow assign the patient to the most likely category already. And from there, move on to your most, or to your directed or targeted workup. Okay? Right. So this is the algorithm that I was telling you about. So this is from Navarro. No, more or less, it will serve as a guide for you to work up these patients. Okay. So these are the initial workups, right? If you cannot really find anything distinct in your history and PE. So if ano pa rin, no positive findings, do your abdominal imaging and then assign to the most likely category. If you're really thinking that this might be infectious, then you can proceed with with workups for infection to the echo to check for IE or even rheumatic fever. And then um, if then you can also do your sinus imaging, your lumbar puncture, work up for syphilis na VDRL, HIV test, um, CMV, EBV, ESO. Of course, there's always it will depend on you, no, on the physician, if you will do all these tests right away or all at once, because of course, they would entail a lot of resources for the patient. So you can really just do more of parang a tiered approach. Ito muna, if you're really thinking, baka if you're thinking of the more common ones, so okay, I'll just do the EBV test first, some common viral infections before doing the rest, no? So that's also a good way to also approach these patients, okay? So for malignancy, then you they can be classified as a hematologic malignancy or a non-hematologic. So as primary care physicians, you can actually order a peripheral blood smear. No? So from a peripheral blood smear, you can easily see if there are blasts or any abnormal cells in the peripheral blood smear before proceeding with a bone marrow biopsy. And then on hematologic, so other um, sources or locations of masses that that are more common, no, like your chest, di ba? So that's why a chest ultrasound or chest CT imaging can also be helpful. Okay, so autoimmune can order for rheumatoid factor or ANA, and if the diagnosis is clear, you can proceed to the uh, directed therapy, or if not, then you can refer for lymph node biopsy or tissue biopsy. And then for other, and then of course, you still think of your other causes, no? Like, is it central or other causes for your prolonged fever? So they will fall under miscellaneous. Okay. So RJ, so let's go back to the case. So now you've done your initial workups. RJ was finally admitted because the fever had been going on for a long time already, and there was decreased oral intake already. So the following workups revealed CBC was normal, CRP was 10, so actually only just mildly elevated. Some labs would give a normal reference of up to 6, but some would also give a reference of up to 10. But usually less than 6 ang normal na CRP. So only very mildly elevated. Urinalysis was also unremarkable. Blood culture, urine negative. Chest X-ray, though, there was suspicious infiltrates in the perihilar area with hilar lymphadenopathy. And the tuberculin skin test was 15 millimeters. So is this a positive or a negative skin test or equivocal? What do you think? Positive ba ang 15? You've had your ano na ba? TB lecture? Although it was also in the in this lecture. Ano ba ang 15? Positive, okay. So yeah, it's a positive more than 10. It's a positive skin test. So what is now your working impression based on the initial lab test that you requested? TB, tuberculosis, pulmonary tuberculosis. Okay, so actually, who answered this one? Very good because you put the site of the infection, no? So you should tuberculosis is actually classified as pulmonary tuberculosis or extrapulmonary tuberculosis. Okay, most of you answered TB. Okay, so yeah, actually, most likely this is a case of um, pulmonary tuberculosis based on the history, the signs and symptoms, the radiologic finding, and the immunologic findings, so which is the TST. So these are the different clinical forms of TB, your exposure, your infection, and disease. So exposure is different from infection, different from disease. So when you say exposure, there's really just a history of exposure. So there you don't have an immunologic evidence of conversion, no, meaning infection. So there's negative signs and symptoms, negative TST, negative labs. TB infection meaning you've been infected already. So this is also called latent TB infection because you've just been infected but you don't have the disease. And so the hallmark for this is your immunologic conversion or your positive TST or IGRA. The in quantiferon, sorry, IGRA is immunologic quantiferon. I forgot what. Interferon gamma release assay. Sorry, nagkaka-senior moments na. So your IGRA right now, I think I have that in the slide, no? Yeah, yeah, sige, sige. So I'll present more on IGRA later. Okay, so the infection is either a TST or an IGRA. TBDC, so you already have signs and symptoms or laboratory findings. Okay, so aside from the exposure, you already have signs and symptoms, and then you may or may not have a positive TST because TST is really has a very low yield, no, low positivity actually. That's why we're leaning now towards more on IGRA na, no, it's a blood test and it's more sensitive. Okay, or you may not have positive radiologic findings, ha, but your signs and symptoms are compatible with a disease process, TB disease process. And so anatomically, they can also be classified as pulmonary or extrapulmonary. And then for bacteriologic status, classification, bacteriologically confirmed or clinically diagnosed. So that's why there's a clinically diagnosed classification because your laboratory might not always be positive all the time. Okay, so what are the unique features of TB? It um it differs from the adult, no, because it presents mainly with protein manifestations, meaning uh, different and non-specific clinical manifestations like your fever, weight loss, body weakness, no, decreased activity or playfulness, minsan ganun lang. And versus a localized disease in adults. So adults would present more commonly with a cough, no? Because um, so kasi localized siya to the lungs. Okay? So there's greater risk for dissemination. So it can actually go to other organs, go disseminate through the bloodstream, and then go to other organs. Greater risk for serious complications and death compared to adults. Of course, because of their lower immunity or immune system. And it's possibacillary in nature, so meaning the bacillary load is less. That's why they're not infectious. They're not able to transmit uh, uh, the bacteria because of their low bacillary load compared to adults. No? So if patients ask you, makakahawa po ba ito, doktora? Actually, the answer there is no, because this is the reason of their possibacillary. Unless and this is also the reason why the sputum AFB is really very has a really a very low yield among children. No, that's why we aside from sputum, we get a gastric aspirate, no, because they cannot really expectorate. And even the gastric aspirate may also have a low yield. So the gene expert now is really the diagnostic test of choice for these patients. So active TB is presumed if the child has three or more of the following criteria. So three or more of the five criteria. So what are these five? The epidemiologic, clinical, immunologic, radiologic, and laboratory. So epidemiologic, that's the exposure aspect. Clinical, so that's why it's very important to ask now the household history if or family members who are sick. Also clinical, these are the signs and symptoms suggestive of TB, which I'll show later on. Immunologic, so this is the TST or the IGRA that I was telling you about. So radiologic is um, the chest X-ray or any X-ray. So let's say if it's a gastrointestinal TB, of course, then the imaging should be in the abdomen or abdominal area. Laboratory. So these would be your if you were able to obtain a tissue specimen for those presenting with mga mass or mga lymph nodes. So that would be your laboratory findings. Or um, the microbiologic also falls under this. So yung mga AFB, gene expert, no, molecular testing, that's a gene expert. Okay. So sa clinical naman, they should present with three also, no? So for the whole criteria for TB, three out of the five. And then for the clinical, di ba, it's just one aspect, one criteria. They should also fulfill three of the following, no? Three of the six. So coughing, wheezing of 2 weeks or more, unexplained fever of 2 weeks or more, loss of weight or failure to gain weight, or loss of appetite, failure to respond to appropriate antibiotic therapy for a lower respiratory tract infection, so unresolving pneumonia with given appropriate antibiotics already, a failure to regain previous state of health 2 weeks after a viral infection or exanthema, so this can also happen, fatigue or reduced playfulness or lethargy. So that's the clinical aspect now of your TB. For immunologic naman, so this could be your TST or your Manto test. Ano pa yung mga other terms? PPD, purified protein derivative, no? But the more appropriate is the TST, tuberculin skin test. So it's a positive test would give you an induration of 10 millimeters or more, regardless of BCG status. And an induration of 5 is considered positive if the child is severely malnourished, immunocompromised, or is HIV infected. So this first three, no, is primarily because of a depressed immune system. So they might not mount a good immune response to the TST. And then close contact with an infectious TB source and persons with the chest X-ray consistent with prior untreated TB. So you you can, for these, you can give a lower threshold kasi because these patients are really at high risk for active TB disease. So that's why they have a lower threshold. Okay. Yan. And then, so the window interval, okay, from the time of exposure to reactivity would be 2 to 12 weeks. So you can really, if you're really in doubt, you can either repeat the test and the exposure is fairly recent and then TST is negative, you can actually repeat na after 3 months. Or you can do the IGRA, which is a higher sensitivity. Okay. And just to show you that there are also reasons for some false positive reactions and false negative reactions. So false negative na actually madami. That's why we tend to get a low yield for TSTs. Okay. And then the IGRA, so interferon gamma release assay, it detects the interferon gamma generated by the T cells, okay, in response to specific MTB antigen. So this can distinguish LTBI from previous BCG administration because it's specific to MTB and not Mycobacterium bovis, no, from the BCG. So this is the test of choice in people who have received BCG and unlikely to return to have the TST read because for the TST, diba, they have to return after 48 to 72 hours for the reading. But for this, you just get a blood test and then results na yung interpretation. So, but in those less than 2 years old, the TST is still preferred because the IGRA has low sensitivity naman. There's really not no good data na for the IGRA in less than 2 years old. They also tend to be false negative. Okay, so that's for the immunologic and then radiologic uh, and laboratory. So these are the different forms, common forms, no, that you might see. So this is the hilar lymphadenopathy. Very common also, especially for primary complex. Now they really present with big lymph nodes. This is the cavitary form. No, so if you see cavitary type of TB, that's really very infectious. Miliary also. No, miliary. This is the millet seed appearance. And then pleural effusion. Actually, if you see kids with pleural effusion, then you have to rule out TB unless uh, you have to rule out TB in these cases. And then for the treatment, so um, you have two treatment regimens now. Before may mga madami pang, but it has been simplified already. So regimen 1 in essence is the shortened therapy now for pulmonary TB or extrapulmonary other than the CNS, bones and joints. So remember brain, bone, joint should be given 10 months or 12 months or the regimen 2. So this is for the extrapulmonary form of TB of the CNS bones and joints, whether new or retreatment. Okay? Okay. So I observed, all right, so that's for the FUO part. Actually, I really mainly focus on TB because for the synchronous session, it's really very common in the Philippines. So it's really one of the um, differentials now that you really have to think of now when you encounter patients with FUO. Okay? Or even with just prolonged fever or fever without source. Okay. So moving on, are there questions for the first part? If there are none, please feel free to type in the chat box. Okay? So I observed that the most common and important route of transmission of hospital pathogens is through direct contact through hands. Most of you answered contact B, contact with respiratory droplets, and a few answered airborne. Okay. So actually, most of you got it right now. It's really the hands. That's culprit. So that's why hand hygiene, please, is very, very important. Now, when you get to the clinics, so what? I sorry, give the 5 moments of hand hygiene. Okay, are you done? See some of your responses. Okay, before patient contact, before aseptic procedure, after body fluid contact, after patient contact, after contact with surroundings. Okay. Okay, very good. Nandun na kasi sa drawing. Okay. So before patient contact, now do alcoholize or wash your hands. If your hands are visibly soiled, meaning may dugo or dumi, whatever, no, you have to wash your hands, no, just not just do alcohol or hand rub. And then before a clean and aseptic procedure, okay. So before getting blood or uh, doing any or accessing the IV line of the patient, please do hand hygiene. After body fluid exposure risk, so after you've drained the catheter, Foley catheter, say you'll be doing this in the clinics, please do hand hygiene. After patient contact, so if you didn't come into contact with the body fluids, but still you touch the patient no, after your vital signs, do hand hygiene, and after contact with patient surroundings because fomites, right? Bacteria can be transmitted also in fomites. So, hand hygiene is just part of the precautions that we have to take. So, what are precautions? What are these precautions? Now, they can be divided into standard or your transmission based precautions. So, when you say standard precautions, this is the set of infection control practices when you're in contact with all patients, regardless of their diagnosis, okay, or presumed infection status. And for transmission-based precautions, these should be added in addition to standard PREC for those with a documented or suspected infection already. So depends on the type of infection or condition that the patient has. So these are additional precautions. So when is the right time to implement standard precautions? As soon as you encounter a patient. And what are these standard precautions? So hand hygiene, use of gloves, gown, mask, eye protection, and face shield when you are at risk for body fluid exposure. Okay. Respiratory hygiene or cough etiquette is actually a standard precaution. Safe injection practices. So when proper proper recapping of needles, no, point of use equipment cleaning. So these are the stethoscopes that you use when monitoring patients, the thermometers. Diba, you use this uh, use this equipment for sharing, right, for different patients. So these are the point of BP apps, no, mga ganon. So these are the point of use equipment that you should actually be cleaning after every use. And then for transmission-based precautions, these are the different categories: contact, droplet, airborne. Contact, so uh, if the condition needs or is transmitted through direct and indirect contact, now through fomites. Droplet if the microorganism is transmitted by respiratory droplet, like your COVID. Airborne if these are transmitted through nuclei. So the droplets are bigger, no more than 5 micrometers in size. Droplet nuclei are very small, less than 5 micrometers in size. That's why they can be transmitted through the air. So these examples of these are your MTV, measles, tuberculosis, varicella, right? So ito yung mga contact precautions. Uh, Clostridium difficile, varicella zoster, or chickenpox, or zoster, or herpes simplex should be using contact precautions, even respiratory viruses, because these droplets can land right and land in surfaces, and you can actually touch them and um, uh, get into contact with them. So these are just some of the conditions that you need contact precautions. And when you say contact precautions, you need um, gloves and gowns, okay, and use of dedicated equipment. So these should be ideally they should really be single use or per patient. And you should not be using the same gowns no when you go from patient to patient. They should be dedicated for a single patient. So droplets again for those diseases transmitted by respiratory droplets. So what are these? Meningo, pertussis, group A strep, um, and respiratory viruses also, like your RSV, para-influenza, adeno, flu, and even viral hemorrhagic fevers like your Ebola, Lassa, and Marburg can be transmitted through droplet. So meningo is just droplet. It's not airborne. So for droplet precautions, you need to protect your mucous membranes. That's what you should remember. So that's why you wear a mask and a face shield or goggles. Okay. So here you can see that the mask is a regular face mask because the regular face mask can already protect you from those big droplets. They're they're very good already in blocking these big droplets. So these patients should be ideally placed in a single patient room. If not, cohort them, no, the same illnesses or the same transmission. You cohort them in one room, and then yon mask and eye protection. And for airborne, so smaller particle size, less than 5 micrometers. And these are the pathogens transmitted through airborne. TB, si MTV, no, si measles, TB, and varicella. COVID, also airborne. MERS-CoV, and avian influenza. You apply airborne precautions. So for airborne naman, these patients should be in a single patient room with a negative pressure room, ideally, no? And here, that's when you'll need your higher grade mask. So you'll need an N95 or higher level, a higher level respirator for these patients. Okay? And don't forget to remove your respirator after leaving the room, no? Uh, But of course, during COVID-19, di ba, because of low resources, we um we practice the one respirator for all patients. But ideally, you should be um using a single respirator for a single patient, and then they should be disposed of after each patient use, ideally. Okay. All right. So which of the following is not transmitted via aerosolization of droplets, meaning airborne? So These are, again, droplets are bigger, the respiratory droplets. The nuclei are the smaller droplets, no less than 5. So which are not transmitted via airborne. Okay, so most of you answered none of the above. So very good. No, you were listening. Um, so si MTV, di ba, are transmitted, plus si COVID also, are transmitted through airborne. Okay? So now write the type of isolation precaution. Which one is contact, which one is respiratory, which one is airborne. Or droplet, sorry ha. Contact, droplet, airborne. Okay, contact, droplet, airborne. Okay. Okay. Right. So, yeah, most of you got it right. Very good. So, contact, right? The gloves and gowns. And then for droplet, the mask, the eye, mouth, and nose protection. Okay, so that's why you need your goggles and face mask. And then airborne N95 or higher. Okay, so just to also emphasize that these precautions are actually you can have a mix of these precautions, right? So you saw in the a list of pathogens. Usually may overlap talaga. So that's why usually combination talaga yung ginagamit natin na ano, like for COVID, you apply your airborne and contact precautions. For chickenpox also, airborne and contact. You should be wearing gowns and gloves kasi 'di ba the vesicles are highly infectious, so you need to apply contact precaution also. So, meningo, they are also droplet and contact. So that's why aside from the mask and face shield, you should be wearing also your gloves and gown when seeing these patients. So usually they're a combination. Okay? All right. So another aspect of healthcare associated infection is the development na of or the prevention of antimicrobial resistance. So that's why we have the antimicrobial stewardship program. So in antimicrobial resistance, non-susceptibility to at least one agent in three or more antimicrobial classes is defined as so there are three kinds of or categories of antimicrobial resistance, right? So is it multi-drug, extensively drug resistant, or pan-drug resistant? Okay, so most of you answered MDR or multi-drug resistant. So most of you actually got it right. So MDR is non-susceptibility to at least one agent in three or more antibiotic classes. So for example, meron siyang resistance sa aminoglycoside, meron na siya sa cephalosporin, and meron na siya sa uh, let's say lang, fluoroquinolone. Oh, so those are three already, no? Even if the rest are susceptible, that patient is already an MDR. Okay? So extensively drug resistant is non-susceptibility to at least one agent in all but two or fewer classes of antibiotics. And then for pan-drug, non-susceptibility to all agents in all classes. Okay. Okay. So actually the trend now is really going to XDR and PDR na eh. So that's why we really have to be cautious no or use our antimicrobials judiciously. Okay, not just in in the hospital setting but in the community setting as well. No, when you practice already, when you prescribe, please use your antibiotics wisely. Okay. If patients most most ORTs are just viral, right? So you can really just give supportive treatment for your patients. Okay, thank you. That's it for our synchronous session for today. Do you have any questions? So if none, may parang wala namang announcement, I think. Okay, so make sure to log in your attendance. And if you have questions, you can send me an email if you have questions. Thank you, everyone.
Thank you, Doc.
Thank you
Okay.
po, Doc.
Thank you
Doc.
po, Doc.